My name is Aileen Murphy, and I'm a general and bariatric surgeon at San Ramon Regional Medical Center. The purpose of this seminar is to educate prospective patients on who are candidates for weight loss surgery, the workup in preparation for surgery, and what to expect around the time of surgery. Please note, this seminar is not intended to persuade you and should not be considered medical advice. Only you, your family, and your doctors know if bariatric surgery is right for you, and further information can be discussed in person during consultation. In 2013, the American Medical Association designated obesity as a disease. This is important because once this is classified this way, patients and physicians can recognize this as something that can be diagnosed, treated, and ultimately prevented. The World Health Organization defines obesity as a chronic progressive disease that results from multiple factors, both environmental and genetic. It can have serious physical, psychological, and economic implications for patients and can be very challenging for the physicians taking care of them. The way to calculate whether you are a candidate for weight loss surgery is to first determine your body mass index, or BMI. This is an equation that is based on a sedentary individual, so does not apply to athletes since muscle weighs more than fat. To calculate, you take your weight in kilograms divided by your height in meters squared. This calculated number is your BMI. Normal BMI is 18.5 to 24.9. Between 25 to 30 is overweight, and 30 and above is considered obese. Unfortunately, the impacts of obesity are vast. There is still social discrimination with economic implications on a personal level, amounting to over $15,000 per year, and on a national level being over $200 billion per year. There are also health implications once BMI reaches 30, with an increase in coronary artery disease, also known as heart disease, stroke, diabetes, and overall mortality. This slide demonstrates the multiple medical conditions that are related to obesity, most notably high blood pressure, diabetes, sleep apnea, and acid reflux. There has also been an associated link of obesity to cancer with increased risk in breast, colon, and prostate cancers. The mechanism is due to the inflammatory response of fat in adipose tissue, which promotes tumor growth and progression. There are several options for weight loss. Diet, exercise, and behavioral changes can be very successful, but above BMI 35, this can be difficult with only 10% loss of excess body weight being affected. This can be ineffective long-term. Weight loss drugs can also be used, but typically side effects prevent long-term use. Weight loss surgery can result in 55 to 75% of excess body weight being lost in addition to diet and exercise. Bariatric surgery or weight loss surgery has been shown to be the most effective and durable treatment for morbid obesity. While it is not a cure, bariatric surgery is a tool to be used with dietary changes and regular physical activity to maintain a healthy weight. Candidates for bariatric surgery include any patient with BMI of 40 and above, or any patient with a BMI of 35 and above with associated medical problems such as hypertension, diabetes, sleep apnea, or reflux. In addition to BMI, patients must be within the ages of 18 to 65, although patients above the age of 65 are evaluated on an individual basis. Patients must also have had failed attempts at weight loss, have no psychological contraindications, or untreated mental illness, be able to understand surgery and its risks, and be compliant with diet and exercise requirements. The bariatric surgery that we perform has both a restrictive component and malabsorptive component depending on the type of surgery. Each procedure is performed using minimally invasive techniques with laparoscopy and robotic camera and tools. In the following slides, I will discuss each procedure: Roux-en-Y gastric bypass, sleeve gastrectomy, gastric band removal with conversion, and intragastric balloon placement. This slide shows the small incisions that are made for Roux-en-Y gastric bypass. 6 small incisions are made to allow instruments to enter the abdomen. The stomach is then divided for restriction, with the small intestine rerouted for malabsorption. This is another picture depicting the anatomic changes to the stomach and small intestine in Roux-en-Y gastric bypass. The stomach is divided with a small pouch created, and the intestines are rerouted to maintain nutrition, but decreased absorption to allow for weight loss. This slide shows the small incisions that are made for sleeve gastrectomy. 6 small incisions are made to allow instruments to enter the abdomen. The lateral part of the stomach is then stapled off and removed from the body. This is another picture depicting the creation of the stomach into a long tube to allow for restriction. The removal of the lateral portion of the stomach has cells that contribute to hunger, including ghrelin. While absorption is not directly affected by this anatomic change, there are hormonal changes that result in similar results to the gastric bypass. The gastric band was popular in 2005 to 2010, but has since fallen out of favor due to complications with erosion and slippage. I show it here as one of the most common reasons for revisional bariatric surgery, with removal of gastric band and conversion to gastric bypass or sleeve gastrectomy. One of our non-incisional methods for weight loss includes placement of the intragastric balloon via endoscopy at a surgery center. This balloon is targeted to patients BMI 30 to 40 and is not covered by insurance, unfortunately. Once in the stomach, the balloon is deployed, then filled with sterile saline, ultimately being about the size of a large grapefruit. This remains in your stomach for 6 months and then is removed endoscopically in a surgery center. Which procedure you ultimately choose depends on your medical problems and preference. There are risks associated with every surgery, and at the time of consultation and subsequent appointments, we will discuss those details. Overall, mortality from the surgery is less than 1%, with likelihood of major complications being less than 5%. Clinical evidence shows the risk of morbid obesity outweighs the risk of bariatric surgery itself, with morbidly obese patients having 50 to 100% increased risk of premature death compared to patients of healthy weight. Bariatric surgery has been shown to be very effective, with most of the weight lost within 1 to 2 years after surgery. The most likely time to regain weight after surgery is between years 2 to 5. On average, 5 years after surgery, patients are able to maintain at least 50% of their excess weight loss. Bariatric surgery can improve or resolve multiple medical problems with reduction in mortality from cancer, coronary artery disease, diabetes, and mortality. This slide shows the multiple medical problems that can be resolved after bariatric surgery. As you can see, there are many. The preoperative workup includes education, with completion of weight loss surgery seminar and support group. Consultations with dietitian and psychologists required by insurance, with pulmonology and cardiology consults dependent on your medical history. The testing required to determine which surgery is right for you include an upper GI series, which is an X-ray to evaluate for hiatal hernia and reflux, and an upper endoscopy. In addition, EKG, chest X-ray, screening labs, and any age-appropriate cancer screening tests must be completed prior to surgery. The weight loss management requirements include 3 to 6 consecutive monthly documentation of weight, diet plan, and exercise regimen discussion, depending on insurance requirements. What to expect when surgery date has been assigned includes a liquid diet for 2 weeks to shrink the liver and make dissection easier. While in the hospital, it will be about a 2-hour surgery with 1 to 2 nights in the hospital. An upper GI will be performed on post-op day 1, and medications will be crushed or broken into small pieces. You will be expected to walk to prevent pneumonia and blood clots and be given liquids, clear to start, then after the upper GI, full liquids, which is thicker in consistency. Once at home, you will be on small pills or liquids for pain control. You will need to practice small sips and avoid gulping. You will need to aim for 60 grams of protein and 64 ounces of water. You will be seen at 2 weeks post-op and every 3 to 6 months thereafter to check labs for vitamin deficiencies, then yearly after that for up to 5 years. Our surgeons are highly qualified experts who have received fellowship training in advanced, minimally invasive, and bariatric surgery. We strive to provide our patients with care that is multidisciplinary, comprehensive, and above all, compassionate. We genuinely hope to provide you with the support that you need to help achieve your weight loss goals. Our bariatric team includes Dr. Diane Kwan and Dr. Aileen Murphy, myself. To schedule a consultation, please refer to the number below. Thank you.